I'm happy to introduce Dr. Davar with you to further talk about the role of the gut microbiome in regulating response and also occurrence of adverse events in patient upon immunotherapy.
So people can hear me okay? All right, perfect. So thank you all for coming. The primary role of this is to talk a little bit about sort of how what we take, what we eat, the stuff in our gut affects how we respond to cancer. The primary goal is we spend a lot of time sort of studying specimens. We really like it when we get these biospecimens from patients. Our primary interest actually is stool specimens. Everybody produces something, hopefully every day. So, if you don't, that's a problem. And also doesn't cost anything. It's actually less invasive than a blood specimen. So we really like collecting these things. So you've heard a little bit about sort of the advances in immunotherapies. I won't belabor the point, but the key sort of takeaway is that everything and the reason people are alive is for all the things in the bottom. And what people don't necessarily realize, and this is, I think, quite transformative, is that people are dying less. All right. So for the first time in the history of humanity, right, in the last 10 years, there are fewer people dying of cancer than there were before. And that's kind of like a big deal. Like, this has not happened with anything outside of vaccines. And the reason for that, and the reason it's not just one disease, meaning it's sort of melanoma and lung cancer, is primarily because of the advances of immunotherapy. And actually, Hodgkin's lymphoma is there as well because of CAR T therapy. And as you heard from Dr. Davar, everybody's sort of focused on sort of the genetic features and the host immune environment. And what we've been studying is this gut microbiome. And all of this started actually about 7 years ago. I was still in training, and I was sitting next to Dr. Davar, and he was like, I think we need to start collecting some stool. And I think most people would have dismissed that as a wacky idea, but I guess I was equally wacky. So I think, he and I thought it wasn't that bad an idea. And so we just started rounding up and getting poop from people. And so this is what we've learned. So you heard a little bit about the antibiotic stuff being bad. And as it turns out, that's firstly true. And the kind of like the main takeaway I would think about that is, think of the amount of time somebody prescribes an antibiotic on the phone, right? So you can get antibiotics right now by just calling into your doctor and coughing. They don't even ask you what you are coughing for. They're like, oh, you're coughing, take an antibiotic. And the same is true of proton pump inhibitors, right? You see that ad on TV, there's this big guy, right? And he's driving, he's just had barbecue, and he's riding a lawnmower. And he stops the lawnmower and he's like, oh, I don't feel good. And you get a proton pump inhibitor. Proton pump inhibitors make you have fractures. They reduce bone density. They reduce the efficacy of immunotherapy, and you can get them over the counter. That is a problem. So I think what we're trying to do collectively is identify the fact that it's so hard to respond to immunotherapy, but it's actually relatively easy to reduce the likelihood of responding to immunotherapy. And maybe the things that you can do to sort of increase the odds of success, maybe we should be focusing on that in addition to identifying new drugs. You heard about the data of fiber, and I think this is quite promising. The key thing to understand is just how much fiber you need, okay? So fiber is great, and I think fermented foods are great. I kind of think that fermented foods are a little better than fiber, not because one is better than the other, but the quantity of permissive fiber that you need is a lot. The amount of fiber that was identified in the MD Anderson data set to be associated with positive outcomes was about 20 grams of fiber. The median intake in the average American is 15. In Pennsylvania, it's 12. In order to go from 12 to 20, you need to eat 2 pints of blueberries a day. So that's firstly a lot of blueberries, but it's also a lot of money because the organic stuff is like $5 a pint. So that's like $10 of blueberries a day. That's $300 a month. That's a lot of blueberries. So fiber is quite good. And at MD Anderson, we're hoping to see the data from these guys. And these guys just, this experiment in which they were shipping diets to people's homes, which I think is actually quite provocative because you're literally getting a meal in the mail and you're eating just that. Hopefully you're eating just that. We don't know if they ate more than that or not. And we haven't seen the outcome of this, but really the amount of fiber they were studying was a lot, about 50 grams. And the major side effect that you get when you eat that much fiber is, does anybody know? Gas, flatulence. That's the major side effect and sort of abdominal side effects. So what we've been looking at is other things like you've heard from Dr. Zaror and Kako about fermented foods, and the data from Justin Sonnenberg is very provocative in this regard. We also looked at what you think you could take in that could be bad besides antibiotics and proton pump inhibitors. And we found that sugars, certain kinds of artificial sweeteners appear to be quite bad. So what are artificial sweeteners? It's a stuff that you think is safe, right? So people thought sugar was bad. And then we started adding artificial sweeteners. Artificial sweeteners were invented in the 1970s. It's actually a byproduct of Teflon. And amongst the many good things that we got as a result of Teflon, people realized that there was this sort of synthetic chemical that sort of tasted, because it had a structure that was very similar to the sugar receptor, it tasted like sugar, but it had no calories because it came from Teflon. It's a non-natural substance. And there's a clear market for this in the 1980s as a result of the war on carbohydrates and fat. And this sort of promulgated through the food industry. It's found in just about everything. People drink Celsius. Anybody drink Celsius? I'm sure many people drink Celsius. It's got artificial sweeteners in it. So it's marketed as a health product, but we just don't know what the long-term side effects are. So we were looking at this partly for two reasons. One, because there was some fairly good data from the Crick Institute and a group in Israel that linked high intake of artificial sweeteners with poorer outcomes to diabetes control, and that this might be associated with the immune system. So we did this evaluation in our patients. These are all people who are getting immunotherapy in the clinic. And we asked them, much like Kako was asking them, just how much sugar you're taking. So we have this questionnaire that we administer. And we can normalize the sugar intake relative to the body weight. We had a preclinical collaborator who was looking at this, and she found that when you add sucralose to checkpoint inhibitor therapy in mice, it makes the cancer grow faster. And we were looking at this in cancer patients, and what we found was that in both melanoma and lung cancer, when you take sugar, artificial sweeteners in particular, when you take artificial sweeteners, your likelihood of responding to immune therapy is much lower. The question is, how high is high? And it turns out it isn't very much. The quantity of artificial sweetness that was found to discriminate between people who did well and did not do well was something like 0.007 milligrams per kilogram per day. So it's not a milligram per kilogram. It's not a tenth of a milligram per kilogram. It's one 1/100th of a milligram per kilogram. That's about 2 cans of Diet Coke. All right. So that's kind of a problem. Like if you take more than 2 cans of Diet Coke that we sometimes serve people, if you were here at lunch, we would be giving you Diet Coke. That actually affects the likelihood of doing well to immunotherapy. And these survival curves are quite stunning because this is the kind of thing that you expect to see, the improvement with a second drug. And what you're showing here is that people who do not take artificial sweeteners at a high level do well, but people who do so appear to do much worse. And there's a mechanistic reason behind it, which is outlined in the paper that's currently under review. Now, what else are we interested in studying? You heard from Dr. Zaror about how we're collecting all of this stuff. Now, this stuff is not easy to do. So firstly, we have to thank everybody who participates in this because we have many, 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 many people going out and asking many, 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 many questions. We ask you what you eat, what time you sleep, what medications you take. So we're thankful for your help. And we also collect the stool, we collect the dietary data, and then we collect it at sort of several different time points, sort of before immunotherapy, during, also during side effects, and also after the immunotherapy is completed. And then we work with our colleagues. So Hassan and I have like this extensive, group of collaborators at the NCI who help us with this. And then actually part of the problem is actually just visualizing the data. It's actually kind of complex to look at. And we've identified in a paper published a couple of years ago, that there's sort of bugs that appear to sort of favorably affect your response to immunotherapy and unfavorably affect your response to immunotherapy. And this was with just one drug. And then it turns out that actually when you have 2 drugs, meaning combination immunotherapy, the bugs appear to be present, but the bugs are actually a little different. And so firstly, 1, you can identify that bugs make a difference, but 2, the bugs that make a difference appear to be treatment or regimen dependent. And we know this for checkpoint inhibitor therapy. We're still working on data in the context of, for example, cell therapy. We also identified that bugs appear to make a difference in terms of whether or not you get side effects. And the people who appear to get side effects that are very serious appear to have bugs that are very different compared to the people who do not get side effects. Now, finally, can you change the bugs? Because the bugs essentially are affected by what you do, meaning you can affect the bugs by what you eat. And if the bugs make a difference in terms of how treatment works, particularly in the people in whom treatment doesn't work, can you change the bugs in order to make treatments work better? And the answer is yes, you can. So certainly, there is the idea of trying to use the diet for this, and diet is actually very important. It's the one thing that is actually within your control, right? You can't control whether or not you get cancer. You can't control whether or not the treatment works, but you certainly can control what you put in your mouths. And so from that perspective, the diet studies that are being done here, I think, are extraordinarily important. But in terms of for people who do not benefit from these interventions alone, can you do something else? And the answer is yes, you can. So what we did was this really simple proof of concept experiment. I use the term simple, but it's actually exceedingly non-simple because what we're doing is we're literally transforming the gut microbiome with a transplant. So we take, in this context, we got stool from people who had done extraordinarily well, and when we gave stool to people who had done very poorly. And while we did not see any benefit in about 9 people, 6 people had cancer that went away completely or stabilized very, very quickly. What was really interesting in these patients is that this one person over here and actually this one individual over here were dramatic for very interesting reasons. This person, for example, did well initially and then got, you guessed it, antibiotics, and the person's cancer started growing again, got a second transplant, and then the person's cancer stopped growing and started shrinking again. So again, another sort of, again, an N of 1 experiment that indicated that the receipt of antibiotics can actually, in this case, very clearly kill a transplant. We then were able to show that some of these responses were very durable. And now other people have done other experiments that have validated this. So a group in Israel did a similar experiment at the same time. This is data from a colleague in Canada, where they've done essentially a very small study in patients who've never received immunotherapy before, in whom immunotherapy plus healthy donors, so not responder-derived microbes, but healthy donor-derived microbes, appear to make people do a little better at a much higher frequency than would be expected with just one drug alone. And so finally, so what can you take away from this? The short answer, I think, is that immunotherapy is outstanding. It's transformative. It's clearly made a difference in the lives of many patients, but most people still do not respond. And that's kind of a problem. And what we think is that the impact of the bugs is really on these people who do not respond. The bugs appear to be the primary reason why people do not respond to immunotherapy in the first instance. Now, it's not the case probably for everybody, but it's certainly the case for a majority of people, for about 30% of the 50% who don't respond. In 2 studies in highly refractory patients, just changing the bugs appear to be enough. And we're now doing other trials. So this is actually a randomized trial that is open that we're running right now. We have a combination known as pembrolizumab. This is a Merck-ASI combination that is currently both in the FDA approved and the NCCN guidelines for melanoma in the refractory setting. It works about very reliably, about 21% of the time. It works in mucosal, it works in acral. And the one major issue with pembrolizumab is that the toxicity profile is moderate. One, it only works about 21% of the time. 2, because of the lenvatinib, about half of 3/4 of everybody has high blood pressure or oral ulcers. What we hypothesize is that the administration of a microbiome agent could actually both increase the efficacy, go from 20 to 45%, but also reduce the side effect rate. So this is being tested in a randomized study here. We also have many, many more larger banking studies. What we are really doing is we're collecting many, many more poop specimens, but also in addition, we're collecting diet data, and we're trying to integrate all of that to try to see whether or not we can get better granularity around what bugs are good and not good. And sort of the general idea is that if ultimately where we see this going in about 10 or 15 years is, and hopefully sooner than that, is that if your bugs are good, your likelihood of you responding to immunotherapy just in its first instance is probably very high. But if your bugs aren't good, the emerging hypothesis is that you might need something else done, whether that's another drug, whether it's some kind of diet, whether it's a kind of microbiome modulating agent. We don't quite know. The interventions are still being worked out. It may be a multiple of those, but you may need something done. And it's fairly simple, to tweak the treatment based on this approach. And finally, we're also very interested in studying side effects. They are now second-generation CTLA-4 inhibitors. For anybody with a relative with colorectal cancer that's microsatellite stable, these drugs now work in MSS colorectal cancer, 21% response rate in microsatellite stable colorectal cancer, where immunotherapy never worked before. The drugs, there's actually 3 agents out there. from Gigagen, from Agenus, from Exelio, used to be one from BMS. And the major issue is that these drugs were designed to sort of activate antigen-presenting cells, and because of that, they actually have a much higher rate of side effects. And so we are very interested in studying side effects, so we actually have a healthy donor-derived microbiome side effect trial that is just about to get underway here. And it's looking at two groups of side effects, basically people with bad joint problems and people with bad colitis. And with, the usual getting biopsies, biospecimens before and after the intervention. So finally, what can you do? Well, very simply, it's fairly simple to know what to not do. So try to avoid artificial sweetness. God didn't make artificial sweetness, probably not good for you in general. Antibiotics. Why should you be able to get antibiotics off the counter? If a doctor is prescribing antibiotics, let's hope it's for the right reasons. And not just because, you had a slight fever after seeing your sick grandchild. Most kids have viral infections, not bacterial. A slight fever is probably not something that we need to necessarily medicate. Certainly, in addition to this, proton pump inhibitors would probably be something to think about. What should you do? Fiber. Again, this is not, you don't have to do this for your cancer immunotherapy. It's just good lifestyle advice in general. Eating more fiber is probably good for you. Probably more than 20 to 28 grams a day. Fermented foods. Across the globe, the cultures that have fermented foods that are embedded in their diet appear to kind of live better. Average age of mortality in Japan, 81. They eat a ton of fermented foods. Average age of mortality in Korea, 82 to 83. They eat kimchi like 3 times a day. Here, we are 78, and we don't tend to eat too much of this. And beer is not a fermented food. It's a fermented product. But in order to get as much kimchi, you'll need to drink a vat of beer. Mediterranean diet appears to be quite promising. My collaborators are all in this room, so we thank all of them. But I'm happy to take any questions.